Hey there, future nurses. Welcome. I'm your host and mentor, and today we are tackling a massive, honestly incredibly important part of your exams in this explainer, endocrine pharmacology. We're going to focus strictly on the high-yield thyroid and anti-diabetic meds that you are virtually guaranteed to see on test day. But listen, we aren't just going to sit here and memorize facts, okay? We're going to really dig into the underlying mechanisms so you can actually think like a safe, competent nurse. Let's do this. Here's the game plan for this explainer. First, thyroid hormone replacement. Second, anti-thyroid medications. Third, exogenous insulin's breakdown. And finally, oral anti-hyperglycemic drugs.
All right, Section 1, thyroid hormone replacement. Let's get right into it. Okay, let's put these two head-to-head right off the bat. Levothyroxine replaces missing thyroid hormone. It is 100% synthetic T4. On the flip side, you've got drugs like methimazole, which actually block thyroid hormone production. Honestly, getting these two mixed up on test day is a classic trap. You always have to ask yourself, is the patient's thyroid working too slow, meaning they need a boost, like levothyroxine, or is it working too fast, meaning we need to pump the brakes with something like methimazole?
So the absolute biggest takeaway here is timing and consistency. You've got to administer levothyroxine first thing in the morning, totally empty stomach, to maximize that absorption. Why the morning, you ask? Well, it amps up energy levels, so giving it at night is basically a recipe for severe insomnia. Also, and this is key, this medication is a lifelong commitment for most patients. Because there are slight little bioequivalence differences between manufacturers, patients should never ever interchange brands without their provider giving the green light.
Let's do a quick knowledge check right away. If a patient is prescribed levothyroxine, which statement indicates successful teaching? Think about what we literally just said about administration timing.
Boom. The answer is B. It has to be taken an hour before breakfast. And here's the deeper why behind it. Taking it with food, especially stuff like soybean flour, cottonseed meal, or calcium-fortified juices, can actually bind the drug and drastically kill its absorption in the GI tract. Oh, and option D, that is a huge red flag. Like we said, this therapy is lifelong. They don't just stop when they feel a bit better.
Moving right along to Section 2, anti-thyroid medications.
Now, what's super testable here is the slight little difference in how these work. Both methimazole and PTU are thioamide derivatives, meaning they stop the incorporation of iodine. They basically starve the thyroid of the ingredients it needs to whip up T3 and T4. But check out PTU, propylthiouracil. It actually has the added bonus of stopping T4 from converting to the more active T3 out in the peripheral circulation. Kinda cool, right?
Time for another pop quiz. And for this one, you really need to connect the dots. If your patient is on thyroid replacement therapy, but suddenly they start presenting with weight loss, a racing heart, and palpitations, what do you think is the most likely culprit?
If you guessed C, toxicity, you nailed it. This perfectly illustrates a massive pharmacological concept. Levothyroxine has a very narrow therapeutic margin. It's like walking a tightrope. Plus, it has a prolonged half-life of 6 to 10 days. So if the dose is even just a tiny bit too high, the drug piles up and your patient swings right from being hypothyroid directly into hyperthyroidism. You have to constantly be on the lookout for these signs of toxicity because they look exactly like a hyperthyroid state. Real quick, if this explainer is helping things click for you and you're feeling more confident, make sure to hit that like button and subscribe to the Nurse Crush It channel. Joining the community means you'll never miss a high-yield review, which honestly could be the difference between passing and failing. All right, let's keep the momentum going. Section 3, exogenous insulin's breakdown. Take a look at these different curves of action as insulin hits the bloodstream. See that steep, super aggressive blue line? That's your rapid-acting insulins like Lispro. Now compare that to the steady, totally flat purple line of long-acting glargine down at the bottom. That flat line is designed to mimic the body's natural basal insulin rate.
To really build that clinical judgment, you simply have to memorize these numbers. No way around it. Notice how regular short-acting insulin peaks in 2 to 3 hours, whereas your cloudy, intermediate-acting NPH peaks way later, right around that 5 to 8 hour mark.
So why are we obsessing over these peak times? Because this is a massive NCLEX trap. The peak time of any insulin is the exact moment when your patient is at the absolute greatest risk for a dangerous hypoglycemic drop. That's when the med is at its strongest point in the blood. If they hit that peak on an empty stomach, their blood sugar is going to completely crash. You absolutely must ensure food is available during those specific windows. Okay, here's a hard and fast rule you've just got to know for emergency situations. Pop quiz 3. When a patient is in a coma or severe DKA and we need to drop their blood sugar right now through an IV infusion, which insulin are we pulling?
The answer is regular insulin. It is literally the only insulin we can push IV or run as a continuous IV infusion during a crisis. Every single other insulin is strictly for subcutaneous use. And when you give it IV, regular insulin starts working incredibly fast, in just 10 to 30 minutes.
Let's try another scenario. Pop quiz 4, all about safety. You grab a vial of NPH insulin. It's an intermediate-acting suspension, so naturally it looks a bit cloudy. How exactly do you prepare this medication before inserting your syringe? You've got to roll it. Gently roll. Never ever shake cloudy NPH insulin between your hands. Shaking it is a huge mistake because it creates tiny little air bubbles in the suspension. Think about it. If you draw up air bubbles into your syringe instead of the actual insulin, you're going to give your patient an inaccurate subtherapeutic dose. So roll it to mix it safely.
Down to the home stretch. Section 4. Oral anti-hyperglycemic drugs.
Metformin is the absolute heavy hitter in this class. It works beautifully to dial back glucose production by the liver, but it has a very specific danger zone. It is 100% contraindicated if the patient has kidney disease. We're talking specifically about a creatinine clearance of less than 30 milliliters per minute. Since metformin is cleared out mostly by the kidneys, poor kidney function means the drug is just going to rapidly build up in the body, and that leads straight to a deadly condition called lactic acidosis.
Which brings us to one of the most frequently tested safety alerts on literally any nursing exam. We're talking metformin and the radiology department. Combining metformin with iodated contrast media, the dye they use in CT scans and angiograms, puts the patient at a crazy high risk for contrast-induced acute kidney injury. And as we just learned a second ago, that acute kidney injury immediately triggers lactic acidosis. So let's see how you handle a real-world curveball. Pop quiz 5. Your patient has a daily order for metformin, but the doctor just ordered a scan using contrast dye. What is your move?
You have to step in and expect to hold that drug the day of the test and for at least 48 hours afterward. When you're out there in clinicals, you should be asking yourself, am I automatically checking the med list for metformin before every single scan? Because honestly, missing this one interaction could literally cost a patient their kidneys. Pharmacology isn't just about memorizing facts to pass the NCLEX. It's about being that final safety check between a medical order and a fatal error. Thank you so much for learning with me today. Keep crushing it, and I'll see you in the next explainer.